Okay, thank you very much, Blake, for the excellent presentation, great information. Our next speaker is Dr. Mark Williams. Dr. Williams is a native of Alabama, received his medical degree in 1980 from the University of South Alabama College of Medicine. In 1995, he received his Master in Business Administration from Samford University. In 2001, he received his Juris Doctor from the University of Alabama School of Law. In 2005, he became a certified physician executive by the American College of Physician Executives. Dr. Williams recently assumed the role of Chief Physician Executive for Tenet Healthcare in Brookwood Medical Center in Birmingham. Dr. Williams is also Clinical Associate Professor for the University of Alabama Department of Anesthesiology in Birmingham. He's been an oral examiner for the American Board of Anesthesiology for almost 20 years. Please join me in welcoming Dr. Mark Williams.
Thanks. Yes, sir. Can y'all hear me okay? Yeah. All that schooling and I still don't know a single thing. I know some of you have already seen much of this presentation in the past. I change it up every time I give it because one of the topics or aspects of the presentation is how society influences how we manage drugs and treat individuals. And so that's really what changes from year to year. But we're going to talk about the basic chemistry, a general approach to how did drug control evolve over time, both in the United States and in different countries. Going to look at the history of amphetamine and what are its clinical uses now. Talk about maybe this very interesting area of cognitive enhancement. And sometimes I think I need cognitive enhancement quite a bit. So here is the first scientific study demonstrating the efficacy of amphetamines. So this is a 1939 advertisement for the use of benzodrine in the California and Western Medicine Journal. It was the very first drug for treating discouragement. But when the drug company, we'll talk about who the drug company was in a few minutes, they found out if we were going to be treating the original indications for this drug, patients with narcolepsy and Parkinson's, darn, we can't make enough money treating just those two populations. Hence, this indication. There's a whole lot more people that might be self-reporting as discouraged than there would be with, at that point in time, especially narcolepsy and Parkinson's disease. The basic chemistry of the amphetamines is very similar to epinephrine and norepinephrine, and the effects are the same. Short-term effects, you all are all familiar with these things. It comes in multiple different forms. It can be injected, inhaled, given in all sorts of routes. It works with the increasing levels of dopamine and norepinephrine, both of which cross the blood-brain barrier, and we all know that dopamine produces a lot of satisfaction when it influences the brain. We also know that it does inhibit drowsiness in narcolepsy. It does work for that. We know it does heighten concentration, going back to the comments of our previous speaker just a few minutes ago at the end of the semester, trying to catch up on a semester's worth of work. So let's talk about maybe something that's very familiar to us that has a lot to do with the history of amphetamine. It's CocaCola. CocaCola, of course, first bottled here in Mississippi. But if you follow very closely the history of Coca-Cola, the original Coca-Cola contained cocaine. The original Coca-Cola was actually put together by a soldier from the Civil War, John Pemberton, who said he had heard about this French drink that combined wine and cocaine, and everybody just really loved it. So he brought that to the United States, and so the original Coca-Cola, or the immediate predecessor to Coca-Cola, was wine and cocaine. Mr. Pemberton lived in Georgia, and Georgia at that time went through a prohibition period 20 years before the national prohibition, so he had to eliminate, not the cocaine, he had to eliminate the alcohol out of the Coca-Cola. And that's when he substituted the sugary compound that is now more resembles the modern Coca-Cola. So he was the sole proprietor of the CocaCola company, and it was considered an intellectual beverage, mainly because you'll see it had the effects of cocaine in it. So the Food and Drugs Act, 1906, comes along, and it's really not attempting to control drugs so much. It's really trying to make sure we know what's in the drug. It was more of a labeling initiative. But now we begin to see, even with that first act, industry influences. It took 27 years to get the Food and Drugs Act passed because industry, those that produced alcohol, those that produced tobacco, those that produced whatever, they all had different views on what should be restricted, what should be in a label. The International Opium Convention was convened in the Netherlands, and it was really to restrict trade of opium around the world. In other words, China was importing a lot of opium to the United States. It also coincided with some tough times in San Francisco. The railroads were complete. There was a very violent discriminatory period during that time against Chinese in San Francisco. So the International Opium Convention, some of the industry players made hay with that, characterizing Chinese as just murderers and people to worry about. This is all from the Hearst Company. The Federal Food and Drug and Cosmetic Act took the Food and Drugs Act, really kind of that's where that ended up at. We had Comprehensive Drug Abuse Prevention and Control Act, 1970. We're getting into the Nixon administration, Nixon time. And now we have formally the Controlled Substances Act, which came out of this, the National Commission on Marijuana and Drug Abuse. And you'll see threads through this whole debate of amphetamines and marijuana throughout the whole history of drug regulation. So President Nixon asked Governor Schaefer of Pennsylvania, who was a very respected individual, to head this commission on marijuana and drug abuse. And again, this was when the Nixon administration was going after drugs. But it was very interesting that the chairman of the commission said, well, we, after all of our studies, draw a different conclusion about marijuana. We don't find that it's that dangerous of a drug, and we certainly don't think people should be subject to criminal penalties with marijuana use. Nixon basically did away completely with the findings of that commission. He also made sure that Governor Schaefer never got his Supreme Court position, which he was destined to get by many. This was actually Governor Schaefer's conclusion about marijuana. And again, it says it's just too harsh a tool to apply. The actual and potential harm of the drug is not great enough to justify intrusion by criminal law. So this fight and struggle goes back, it goes way back. So all the physicians in the room know about this. Schedule I drugs, drugs that have a high abuse potential, no currently accepted medical use, lack of accepted safety, and we all know that these are some of those drugs. Cannabis right here, I'm sorry for the little formatting change, but peyote, which is a plant used by southwestern Indians. LSD, heroin, we've heard a lot about the heroin epidemic lately. Schedule II drugs, which have some potential for abuse, but they do have accepted medical uses in the United States, but they can lead to psychological, physical dependence. This, as you all recognize, is our current DEA drug classification scheme. And of course, it includes these drugs. And you're hearing, again, I formatted from Keynote to PowerPoint, so I'm sorry, but you can tell what these drugs are. Specifically, adderall, Ritalin, and all the other amphetamines. So you just saw how we in the United States classify drugs. Do other countries classify drugs in different ways? So some other countries say, well, let's just look at, the United States has never included social harm in their drug classification schemes. They do mention dependence, they do mention physical harm, but what do other countries do, for example? So here's a very in-depth analysis, United Kingdom some years ago, and it shows physical harm and the likelihood of dependence. And some of that's not unexpected. You've got heroin, cocaine, and tobacco. in the upper right as probably 3 of the most dangerous drugs if you look at harm and dependence. You know, it's just interesting. Marijuana lives in the middle. Amphetamines live in the middle. Benzodiazepines live in the middle. But alcohol was never going to be regulated by anybody because all the manufacturers of alcohol had tremendous political influence. But if you look at this very elaborate scheme, and I know you can't see it, but it takes overall harm and it breaks it down to all those different categories, you know, such as family adversities, environmental damage, crime impact, injury. And if you look at that and you say, okay, if we take all those things, where did the drug sit? Again, number 1 is alcohol. Number 2 is heroin. Down in here you get cannabis. You can see for yourself, it's just sort of interesting how our politics lay these things out. This little segment in here, heroin, and I can't remember this, can't read it, and this one right here, this is crime. These are the criminal penalty pieces. This is putting people in jail. And here's another more readily visible, readable scheme. And again, the crack cocaine, why would the crack cocaine be different than the cocaine? It's because of differential penalties, criminal penalties for crack versus regular cocaine. It's the same drug. Okay, so we often find government policy is conflicting with scientific evidence. This also dovetails with a very recent challenge. It's not so, it's been recent public recognition. It's not a recent problem. But if you're in Mississippi or Alabama and you know that, and you're trying to balance a state budget, and we as physicians tend to focus on Medicaid expansion or Medicaid effects or education, there's also this other huge piece of the budget, which is keeping people in prison. So you all know that in Alabama especially, and in the Deep South, we imprison people at a rate that no other country at no other time in the world has done. And that comes at great expense. In fact, it comes in Alabama, that amounts to almost $500 million a year. And 70% of these crimes are thought to be related to how we manage drugs and the consequences of using drugs. So go back to amphetamine. This is sort of where we talked about. This is a gentleman named Gordon Ailes. He looks very academic. You know, it's like, wow, I kind of expected to see an old bearded professor. He was a British researcher at UCLA. And he comes up with this little compound that really other people have seen in the past. But he says, boy, this amphetamine is kind of interesting. So he says, I'm just a single professor. Maybe if I could find a drug company that can help me market this wonder drug, we can really make a lot of money. And so they did, Smith, Kline, French. If you've been around for a while, you know that company doesn't exist in that name anymore. But I grew up being very familiar with SKF in my professional world. So what was it about this drug that Gordon Ailes really liked? Well, back in his times, it was not uncommon for the researchers to take the drugs themselves and see what the effects were. So he said he gave him a dose of 50 milligrams IV of amphetamine, which is a big dose. He says, this is directly from his diary. 7 minutes later, his nose is dry and clear. His blood pressure climbed dramatically, but he had a feeling of well-being. He grew chatty at a party and considered himself unusually witty. Rather sleepless night, mind seemed to run from one subject to another. And indeed, that's a very, very well-known effect of amphetamine use. So we're off and running in the United States with amphetamine. Really synthesized at Hopkins. Mr. Ailes picks it up, sends it over to SKF. Within a couple of years, SKF introduces the inhaler, the benzodrine inhaler. And then a couple of years after that, they introduced the oral form that's offered free to any physician, and none of this has had any clinical trials at this point. It's a drug looking for a disease. So here's our favorite Shirley, what was her name? Shirley Temple, yeah. She's one of the first ones to advertise for this great inhaler. She's got that thing stuck up her nose saying, man, head colds, it works great. Here's, you can't read the print here, but again, here's our Benzedrine tablet, an ad, and basically the gist of it is, has Grandpa been really grumpy lately? Is he beating the kids with this newspaper? And here, your golf game off, try some Dexedrine. Your golf game will improve. Do you think the world has really changed so much now and how we'll see. The biggest use of amphetamines that really introduced young adults in several generations to the effects of amphetamines was in our military. Heavy pharmaceutical and physician promotion during the 30s and 40s. Along comes World War II, and every country, major countries, is just continuously peddling amphetamines to soldiers. The German Blitzkrieg was thought to be so successful partly because all the German soldiers were fueled up on amphetamines. And even today in the middle of the East, it's military policy to give soldiers amphetamines if they need it for sustained attentiveness and whatever. In America alone, just for World War II, purchased 250 million tablets from SKF. So SKF was realizing the dream of making plenty of money off of amphetamines. And in fact, the United States military was very proud of this. Their pilots could fly far more missions than those darn weak-kneed Canadian guys who didn't take amphetamines. All right, Pervitin, that was the German form. Every German soldier carried Pervitin, and their Pervitin is methamphetamine. Available to high-flying personnel, free of charge, to physicians in the armed force. Send in a little coupon, you get as much as you want. Now we're giving it for menopause. Severe depressions and menopause. If you have any apathy or psychomotor retardation, here's the soldier piece again, lock and load. Here's perhaps one of the ones that more people in the room will recognize. Here was, my gosh, we had got the miracle drug now. This is good for everything. And in fact, it's so good, everybody in high society should be using amphetamines. And if they get a little high on them, we now have a new compound that's combined with barbiturates. It can help you level it out. So the ads go on. Journal of the American Medical Association, AMA, supporting all this. For the patient with mild depression, anybody who's apathetic or discouraged. Oh, and this is the one with the new phenobarbital, recommended for patients who can't take amphetamines alone. So it's not the first time us in the medical profession have promoted products that might be not considered to be in the public interest. The AMA, if many of you all know, were vigorous supporters of tobacco use and smoking. I mean, most of the ads featured physicians. And they talked about more thoracic surgeons smoke than any other specialty. And it said, when some evidence began to, it's the Surgeon General, the one who came from Alabama, was trying to tell the public about the dangers of cigarette smoke, and that was ignored by the AMA for 20 years. When it sort of became evident that there might be damage from smoking, that's when they introduced the filtered cigarette. And the ads would say, cleaner than the air you breathe without a cigarette. But back then, the filters were made out of asbestos. So the micronite filter by Kent, they don't have that little part about asbestos in there. This was the real panacea, the diet phenomena, when a doctor could go and buy from a manufacturer at this cost and turn around and sell it to a patient at that price, because at that point they were now available off-brand. So now we have more scrutiny of the amphetamines, and you think, well, with all this out there, there would be more regulation. Well, there was regulation of amphetamines, only the IV form. So there was the hot cover. Who remembers this? The Fen-Phen. This was the miracle drug. This was going to make everybody look like that person on the cover. And what happened, of course, is, everybody knows, is it turned out to be a disaster. And in Mississippi alone, Mississippi in the South, they were very preoccupied with this Fen-Phen thing because there are so many plaintiffs' attorneys in Mississippi and Alabama. this $22 billion gold rush for the attorneys, it turned out that the $22 billion that was distributed, 1/3 of the plaintiffs, not the attorneys, who got an award, 1/3 never took fen-phen. So it was just a real poor part of history in the legal profession. There was a lot of deception. And if you lived back there in '71 in Vicksburg, you knew there were some big attorneys that went down on their fen-phen stuff. So fen-phen came and went. It was a great pill. It came and went. So what can we use amphetamines now for? Narcolepsy, ADHD. There are some other off-label uses as anorectics and atypical depression. ADHD, one of the most common childhood disorders. You all know this, 3 different types. Early in history, it was called an abnormal defect of moral control. This is how many kids or people are on ADHD just through that time period. It grew very rapidly in the 90s and later. This was a New York Times editorial in 2013 that was accompanied by this national survey from Children's Health that talked about how many kids. So you see on this right here, 20% of boys ages 14 to 17 at that time were on amphetamines, and it was especially prevalent in the South. For 2 years, this remained the New York Times editorial that had more responses than any other editorial in New York Times history. And this is some commentary about ADHD. It's hard to believe there would have been a 50% increase. Could Big Pharma be leading this? Well, the suggestion coming out of that was that there were so many people that were taking amphetamines, there was actually suggestions that before you take the SAT or ACT, you be drug tested, because that student who was taking the amphetamine might have an inherent advantage on that exam, and was that fair? Yeah, obviously some people believe that ADHD is overdiagnosed. There seems to be a consensus that it is way overdiagnosed. It is a real disease, but something's pushing this. So, adderall. As a result of the use of these drugs in the military, society effectively says they're okay. So it's hard to come out of one environment and say, I take these drugs every day, and now when I step into a different environment, it's against the law. So it's very difficult for society to go take 2 different positions simultaneously on a drug. We know that amphetamine is spread throughout all parts of society. There was a study that came out of UAB 2 months ago that looked at people who are trying to make a living that are below the middle class level and often hold 2 jobs. They're finding that segment of our population is increasingly using amphetamines just to do their work. We hear about the development of clandestine labs and distribution channels, and you know that was the Breaking Bad theme. It was a methamphetamine, one of the most popular television shows on TV. So when you have all this widespread use of amphetamines, you often lose track of where is the appropriate use. So talk a little bit about abuse and addiction. And so we're here today really because of this. And Scott, Dr. Hamilton's already alluded to this, is that when we take all the people who die from drug abuse or drug overdose, what we as physicians in this room prescribe dwarfs what people take illegally from other channels. It's our pen and our prescriptions that are doing these things. And you often don't hear the medical profession really stepping up and taking responsibility for that. So back to amphetamine chemistry. If you take too much, you take a big dose like Gordon Ailes did at 19, 20-something, 50 milligrams IV. He's probably lucky he didn't die, because that first huge dose causes your blood pressure to go very high. You can stroke out. You can have a heart attack. You can get hyperparexic. That leads to downstream complications from things such as septicemia. people on amphetamines, it's very interesting tolerance. If you take low levels of amphetamines for long periods of time, tolerance usually doesn't develop. But if you take higher levels for a period of time, tolerance does develop. So you might see people who have ADHD who have taken drugs for a long time, that very modest dose, and when they stop, there's really no untoward ill effects. And many people will say that low level given in the right patient with ADHD has prolonged, persistent, positive effects. This is just what we just mentioned. For those college students that took those whopping doses of amphetamines for a few days, they're very familiar with the crash period. Fatigue, depression, dreams, agitation, but it's just a painful, difficult period that pretty much goes away. Methamphetamine. There's often much made in our society about the good amphetamine and the bad amphetamine. Methamphetamine is often called the bad amphetamine. However, it is used in the treatment of ADHD, and it's the one that if you take a matchbook and some iodine and ephedrine, you can make meth. It does have more potent CNS activity, but again, we got to be very careful how drug companies and government agencies and other folks characterize these distinctions. Methamphetamine is basically amphetamine, and amphetamine is basically methamphetamine. We can talk about degrees of difference, but there is no good amphetamine and no bad amphetamine. That distinction is really false. And again, that's methamphetamine now in a packet that makes it look like sugar. You can still get coupons for Desoxyn, which is another amphetamine. Let's see. Now, back in Haight-Ashbury times, most of you don't remember this, the people who used amphetamines intruded upon that culture because at that time that was a love drug culture, and those amphetamine users were high energy and kind of difficult to be around. And then when the Breaking Bad thing came around, there was further sort of characterization of those bad amphetamine users as Hell's Angels, motorcycle riders, and those sort of stuff. So society began to associate amphetamines with these disparate groups. Now, when you talk about methamphetamine and its impact on communities, many of you have seen these books about how methamphetamine labs and users can destroy entire communities. And it was a big criminal problem that's gotten a little better. But again, that's unregulated use of methamphetamine in a criminal environment. That's the Breaking Bad TV program. Methamphetamine is more associated with permanent brain damage by a degree. And what you see characterized in the ads for methamphetamine being so bad is usually the effects like this. They go to great length to show what chronic methamphetamine use can result in, but they don't tell you what chronic amphetamine use at high levels can result in. Now, here was the Vietnam experience, and this is the rate of mental breakdown among American soldiers per 1,000 soldiers. This just came out in the Atlantic Monthly, the drugs that built a super soldier. And while those soldiers were in Vietnam, given large amounts of amphetamines, the American military was very pleased that the rate of mental breakdown was a whole lot less than the other wars. You know, it's kind of like that amphetamine allowed them to cope with that immediate distress. But the war ended, people come home, and they find that 15% of the soldiers who fought in Southeast Asia had PTSD because they were never treated for the actual stress with anything other than a pill at that immediate time. Amphetamines, let's go to the academic environment. We know it improves academic performance. We know that there are a lot of famous people that use amphetamines. These are some of the folks that lived most of their professional lives chronically abused to amphetamines. John F. Kennedy, because he had chronic back pain, used a lot of amphetamines and other medicines. Hitler was thought to always be on amphetamines, methamphetamine. Johnny Cash, some other famous musicians. This is one of the most famous mathematicians in history who continued to solve complex math problems into his late 70s, which is almost unknown in the mathematician world. And he said he could never go a day without being on amphetamine, because if he did, he felt like his day became a blank. Other folks that are very famous users of amphetamine. So, someone walks into your office and says, you know, I've heard that amphetamine really helps you think better, and I'd like some. I'm not a kid, I don't have ADHD, I don't think, but I'm 60 years of age, my mind's beginning to slow. Can we give them amphetamines for that? And you have a lot of folks talking about what we call cognitive enhancement. Why not? If a low level of amphetamine helps us perform our job better, why not give amphetamines? Again, we're being drawn seductively into this argument of more drug use. So, if you talk about, if I'm an athlete, it's okay to use physical enhancers. Why, as a non-athlete, can't I use a mental enhancer? If I'm competing for a job with a younger person for a hospital administration job, and I know that I can take an amphetamine the night before and make me look a lot better, why can't I do that? There's even agencies and groups and associations rising up talking about a phenomena of cognitive liberty. It's my brain, why can't I do what I want with it? And here's a gentleman, professor of law and genetics at Stanford, that says we simply need to think hard about this stuff. We can't have knee-jerk reactions. This is another interesting article talking about the amphetamine explosion. Everybody in New York City is characterized as using amphetamines just to keep up with the modern world. But even in that article, they describe it as a Christmas package with a time bomb inside. We've decided as a society it's too easy, too expensive to modify, so we just medicate. You hear a lot about the opium epidemic and treatment. What you're not hearing as much about is that there are a whole lot of these young kids now that are on ADHD, treatment drugs, and we're now seeing a tremendous amount of amphetamine rehab and problems. Skip that one. So I'll wrap it up with a couple more. So I'm doing my research the other day, and maybe you all are real familiar with this disorder. BED, who's familiar with BED? Okay, and I mean, I'm not a psychiatrist, I'm an anesthesiologist, I have an interest in this, but I thought, well, maybe I haven't been reading much. I hadn't heard of BED. And of course, binge eating disorder. Recently added to DSM-5. Most of the research, and some folks say the research was almost laughable. It's 2 clinical studies. It happened to be sponsored by, surprises, a drug manufacturer. And it was rushed through the FDA process for a drug that's been around for 20 years. But now we have a new indication for an amphetamine. And we got the beautiful ad, you know, the nice looking lady here saying, gosh, does this harken back to what we saw in the early 1900s? It's the same thing. It's all driven by the drug company. So when I Googled BED, I thought I'd come up with a bed, like the bed. But the very first ad on Google, sponsored by the ads company, the very first one for BED is learn about BED at the bingeeatingdisorder.com. Powerful influences by pharmaceutical companies. And of course, what we would be treating patients on is what they would simply be reporting. There is no scientific metric or measure to determine whether this patient needs this. I don't discount that some of us have a disorder with eating that might benefit from amphetamines. So, my last slide, I'm looking at a sign as I walk into here, and apparently there's an ADHD conference in October here at Hattiesburg Clinic, and I don't know who is sponsoring it, but it talks about the use for ADHD, and there's something else, and it says, and the indications now for executive function disorder. Executive function disorder. And I'm thinking, that sounds like me. And so the reason I updated this slide pack is because I went back to that drug company and I said, well, what is executive function disorder? You have problems organizing materials and setting schedules. You misplace papers, reports. You have trouble keeping track of personal items. So my overarching point of this talk is if we are the learned intermediaries as physicians that should be determining what our patients should be taking, we have to be aware of the powerful influences that drug companies and other folks drive through all kinds of avenues, direct-to-consumer advertising, stuff like this. And I think that's an obligation we have to our patients. Because I have executive function disorder, but I'm a little reluctant to take amphetamines for that. So thank you very much. That was a little bit rambling.